Laryngospasm is defined as the magnified glottic closure reflex in response to noxious stimuli of the superior laryngeal nerve. The incidence of laryngospasm in the pediatric population varies from 0.01 to 14%. 68% of laryngospasms occur in patients less than or equal to 5 years of age. 57% of laryngospasms occur in patients less than or equal to 3 years of age. Induction and emergence are the periods of anesthesia in which the risk of laryngospasm is the highest. Complications of laryngospasm include oxygen desaturation, bradycardia, obstructive negative pressure pulmonary edema, pulmonary aspiration, and cardiac arrest. The airway is innervated by two nerves. The glossopharyngeal nerve innervates the pharynx, and two branches of the vagus nerve innervate the hypopharynx. The glossopharyngeal nerve, or cranial nerve 9, is a mixed cranial nerve that carries afferent sensory and efferent motor information. To assess this nerve, one can stimulate the posterior wall of the pharynx to elicit a gag reflex. The glossopharyngeal nerve carries afferent or sensory information to the medulla, and it then synapses with the vagus nerve and spinal accessory nerve. The vagus nerve, or cranial nerve 10, is a mixed cranial nerve that innervates the hypopharynx. The vagus nerve is separated into two branches, the superior laryngeal nerve and the recurrent laryngeal nerve. The superior laryngeal nerve divides into the internal and external branches. The internal branch provides the sensory input to the hypopharynx above the vocal cords. The external branch provides the motor function to the cricothyroid muscle of the larynx. The recurrent laryngeal nerve provides sensory innervation to the subglottic area and the trachea. The right recurrent laryngeal nerve loops around the brachiocephalic artery, and the left recurrent laryngeal nerve loops around the aorta. The normal laryngeal reflex occurs during swallowing, expiration, and coughing. For example, during swallowing, the afferent fibers contained in the internal branch of the superior laryngeal nerve are stimulated. As a result, the sphincteric closure of the airway protects the lungs from aspiration. Examples of active laryngeal reflexes are coughing, expiration, and swallowing. Examples of passive laryngeal reflexes are laryngeal closure apnea and laryngospasm. The pediatric airway is unique and different from the adult airway and can place the pediatric patient at increased risk for laryngospasm. The occiput is large and prominent. The larynx is located in a more cephalic and anterior position, extending from C2 to C4 and pointing toward the nasopharynx to facilitate nasal breathing. The tongue is large relative to the submental space, making it difficult to displace and manipulate during direct laryngoscopy. The epiglottis is long and narrow. The vallecula is shallow. The arytenoids are large in relation to the lumen of the larynx. The subglottic region is conically shaped and smaller than the glottis opening. The cricoid cartilage is the narrowest portion of the airway. The lumen is an ellipsoid structure, and it is lined with pseudostratified epithelium that is easily injured. In the awake infant and child, the tongue and the upper airway muscles, such as the genioglossus, geniohyoid, sternohyoid, and sternothyroid, tense the pharynx, preventing collapse. In the anesthetized infant and child, the neural cavity of the airway muscles are inhibited, resulting in pharyngeal narrowing or collapse. Pediatric patients have very compliant chest walls with predominantly type 2 fast-twitch muscle fibers in their diaphragm and accessory muscles. Therefore, they are at high risk for muscle fatigue, respiratory distress, and arrest. Recommendations for pediatric airway management include: place a rolled towel under the shoulders to help align the oral, pharyngeal, and laryngeal axes during laryngoscopy. Avoid the sniffing position for laryngoscopy with neonates because this could move the larynx into a more anterior direction. Vigilance is key. Pay close attention to these patients' respiratory effort and ventilation. Risk factors for laryngospasm include patient, surgical, and anesthesia-related factors. Patient-related risk factors include high-risk airway anatomy and pulmonary history, such as airway anomalies, elongated uvula, obstructive sleep apnea, whooping cough, history of choking during sleep, asthma, first or second-hand smoke exposure, and recent upper respiratory infection. Other factors include young age, ASA4, premature birth, GERD, and electrolyte disturbances such as hypomagnesemia and hypocalcemia. Surgical risk factors include airway procedures such as bronchoscopy, tonsillectomy, adenoidectomy, esophageal endoscopy, appendectomy, hypospadias repair, and transplant. Anesthesia risk factors include vocal cord irritation such as irritation caused by secretions, mucus, blood, or a suction catheter. Another anesthesia-related risk factor is choice of inhaled anesthetics. Desflurane has the highest incidence of laryngospasm, followed by isoflurane, halothane, and sevoflurane. The inexperienced anesthesia provider is noted as another anesthesia-related risk factor. Potential explanations include lack of knowledge of institutional protocols, poor recognition of laryngospasm, lack of clinical experience with the pediatric population, or a reluctance to call for help. Finally, depth of anesthesia is cited as one of the most important anesthesia-related risk factors for laryngospasm. Depth of anesthesia is determined by the patient's response to noxious stimuli such as oropharyngeal suctioning and jaw thrust. A deep level of anesthesia is evidenced by central pupils and irregular respiratory rate, breathing pattern, and tidal volumes greater than 6 milliliters per kilogram after noxious stimuli. A light level of anesthesia is evidenced by breath holding, apnea, cough, or laryngospasm after noxious stimuli. The literature also defines a deep anesthetic plane in terms of concentration of inhaled anesthetic and BIS level. Anecdotal references in the literature define a deep anesthetic plane as the effective concentration of a drug for 95% of the population, or ED95, such as end-tidal sevoflurane 2.2%. Others suggest 2 times the MAC of a volatile anesthetic. If a BIS monitor is used, a level of approximately 40 could indicate a deep plane. These criteria should not be used alone to determine depth of anesthesia. Rather, they should be used in conjunction with the aforementioned patient responses to noxious stimuli. Depth of anesthesia was originally described by Arthur Goodell's Stages of Anesthesia article in 1927 for an ether anesthetic. It is important to understand depth of anesthesia because the loss and return of active laryngeal reflexes, things that cannot be seen, can be predicted by using other means such as respiratory pattern and rate, things that can be seen. Each patient progresses through stages 1 through 3 during induction and maintenance of anesthesia, and progresses from stages 3 through 1 during emergence. Goodell's first stage of anesthesia is the stage of analgesia and amnesia. This occurs from the beginning of induction to the loss of consciousness. This stage is divided into 3 planes. The first plane is pre-analgesia and pre-amnesia. The second plane is partial analgesia and total amnesia, and the third plane is total analgesia and total amnesia. The patient will interpret a knife incision only as touch, the sensation of being that of a blunt instrument drawn across the skin. The patient can protect themselves from laryngospasm in this stage because the active reflexes, such as coughing and swallowing, are present. Goodell's second stage of anesthesia is the delirium or excitement stage. The sensory and inhibitory areas of the cortex are depressed, and the corticothalamic fibers are interrupted. Since the activity of the higher centers is abolished, the secondary centers are free to produce their uninhibited and more primitive manifestations. Nervous center response to stimulation is exaggerated and expressed in more or less violent physical activity. Muscle tone increases, the jaw sets, eyelids close, skeletal muscles stiffen. What does this mean and what will you see? The respiratory rate and tidal volume will be irregular. Heart rate and blood pressure may slightly increase, and muscle tone will increase. The involuntary movement of the eyes will be seen as dilated pupils and a disconjugated gaze. It is best not to stimulate the patient at this time, such as during emergence, because active laryngeal reflexes such as cough and swallowing are blunted, but passive laryngeal reflexes such as laryngospasm can be elicited. The patient is at increased risk of laryngospasm at this time because he or she cannot protect his or her own airway with a cough if, for example, secretions fall onto the vocal cords. The normal response would be to cough, however, without the cough reflex, the response is now to close the vocal cords to protect the lungs from aspiration. Goodell's third stage is the surgical stage, which is divided into 4 planes. In stage 3, higher centers of the brain become completely depressed and emotional activities are abolished. Planes 1 and 2 signal total loss of consciousness. Respirations are regular, muscle tone is decreased, pupils are normal size and reactive, and the active airway reflexes of cough, gag, and swallow, as well as the passive reflexes of laryngeal closure, apnea, and laryngospasm are absent. Planes 3 and 4 signal total muscle relaxation. Pupils are non-reactive, and spontaneous respirations stop. Stage 4 is the anesthetic overdose stage or medullary paralysis stage. This is a period of failure of vital centers. Respiratory and cardiac centers are completely depressed by anesthetic overdose and hypoxia. The myocardium becomes toneless and ceases to contract. The EEG shows a horizontal tracing. Cardiac arrest is imminent. Laryngospasm can be either partial or complete. A partial laryngospasm occurs when both vocal cords are closed, but a small lumen remains patent. Some ventilation can still occur. A complete laryngospasm occurs when the larynx completely closes, the false vocal cords occlude, and the intralaryngeal portion of the epiglottis and arytenoid cartilages also close. Partial laryngospasm is manifested as some chest movement and a mismatch between respiratory effort and bag movement. Inspiratory stridor may be heard. Complete laryngospasm is manifested as no chest movement, no bag movement, an inability to ventilate, and silence. No stridor will be heard. Both partial and complete laryngospasm will exhibit tracheal tug, paradoxical movement of the chest and abdomen, oxyhemoglobin desaturation, bradycardia, and central cyanosis. We developed a 5-step laryngospasm management algorithm for the inexperienced anesthesia provider. We highlight each step. Step 1 involves removing the offending stimulus and calling for help. Early recognition of laryngospasm depends on the provider's vigilance and attention to the patient's respiratory effort and ventilation. Once a laryngospasm is recognized, the provider should remove any offending stimulus, such as an LMA or oral airway, and call for help. Once laryngospasm is recognized, the offending stimulus, if present, is removed and help is called. The provider should provide CPAP with 100% oxygen. If the laryngospasm has not resolved with CPAP and 100% FiO2, optimize the airway with jaw thrusts and chin lift. Often this occurs simultaneously when applying CPAP at 100% FiO2. If the laryngospasm has not resolved by applying positive pressure with 100% FiO2, jaw thrust, and chin lift, deepen the plane of anesthesia with propofol 0.5 to 0.8 milligrams per kilogram IV. Laryngospasms almost always involve a complete obstruction. Therefore, increasing the concentration of inhalational agents may be ineffective in increasing the depth of anesthesia alone. Propofol will effectively increase the depth of anesthesia with a patent IV. If all of the aforementioned interventions do not break the laryngospasm and the patient continues to desaturate to an oxyhemoglobin saturation of 85% or less, administer succinylcholine 0.1 to 3 mg per kilogram IV or 3 to 4 mg per kilo IM, plus atropine 0.02 mg per kilo IV or IM. Administer atropine with sucks because sucks given in the presence of severe hypoxia is associated with severe bradycardia and cardiac arrest. Let's take a look at our patient, Connor Jones. Connor Jones is a 3-year-old male presenting with a diagnosis of tonsillitis. He is scheduled to have a TNA today. Connor has no known drug allergies and weighs 17 kilos and is 37 inches tall. He is an ASA2 with a normal airway. He has been NPO for 8 hours. Here is Connor's review of systems. We have highlighted pertinent risk factors that put Connor at risk for laryngospasm perioperatively, such as secondhand smoke exposure, recent upper respiratory infection, premature birth, and GERD. In summary, Connor was born at 28 weeks. He has a history of GERD and obstructive sleep apnea. He takes Pepcid for his GERD. His parents smoke approximately 1 pack per day in the house. Connor had an upper respiratory infection 3 weeks ago, which has since resolved. He had a BMT at 18 months of age with no anesthetic complications noted. Connor is now ready for the OR. To summarize the intraoperative course of events, we use the patient handoff tool. This patient is 3 years old, undergoing TNA in the supine position. He has no known drug allergies and received Ansef 500 mg IV pre-incision. He is undergoing general anesthesia via 4.0 cuffed ET tube at 12 centimeters at the lip. The skin temp probe shows he is normothermic. His 22-gauge peripheral IV is in the right saphenous vein. Currently breathing spontaneously on PSV Pro and has received fentanyl 15 mics and Tylenol 170 mg IV. No neuromuscular blockers were given. Connor's TNA is complete. The provider is emerging and extubating him at the end of the case. The provider does not note any fog in the face mask and assesses the patient is not moving any air. She squeezes the reservoir bag and cannot ventilate the patient. Help is called and she administers CPAP with 100% FiO2. The provider continues CPAP with 100%. When help arrives, jaw thrust and chin lift are attempted to optimize the airway. The laryngospasm still has not broken, so the provider administers propofol to deepen the level of anesthesia. The provider still cannot ventilate the patient after deepening the anesthetic, so she administers succinatropine. The provider can now ventilate the patient. Connor's respiratory status stabilizes and is transferred to PACU, where he continues to be monitored.